we begin with another TOG. Okay, this is Caesarean Scar Ectopic Diagnostic Challenges and Management Options. So this is the TOG which is specifically meant for the Caesarean Scar Ectopic. Generally, from TOG we expect SBA, but once I think in September 2021 they have asked EMQ from this particular TOG, and it's really confusing because there are so many types of management in the Caesarean Scar Ectopic. Okay. So listen to this particular talk carefully. We will discuss which type of management is to be selected. Okay. Now, incidence is rising due to increasing number of cesarean section. Early diagnosis is essential to reduce the morbidity. High index of suspicion is needed in women with relevant history. Ultrasound is the diagnostic tool of choice. Okay. Management, we know that traditional medical or surgical is there. Other is the interventional radiology. Okay, a comprehensive management plan should include thorough counseling, surgical expertise, and access to the blood transfusion. Okay, and there are two very important risks in Caesarean scar ectopic, that is a severe hemorrhage and hysterectomy. Okay, so these two risks which we have to keep in mind when we talk about Caesarean scar. One is an hemorrhage, second is a hysterectomy. Okay, so Caesarean scar pregnancy is a rare form of ectopic pregnancy where the G-sac implants into the previous Caesarean scar. Incidence is around 1 in 1800 to 1 in 2500. Okay, this figure also you can remember. Caesarean section scar ectopic is around 1 in 1800 to 1 in 2500 of all pregnancies. Okay, among women with at least one previous Caesarean section and diagnosis of ectopic pregnancy, 6.1 are estimated to be C scar pregnancies. Okay, so if you have a previous scar and the patient is having ectopic, there is a 6% chance that it will be Caesarean scar ectopic. Okay.
Sir, this is 6.1% in previous cesarean due to breech pregnancy or any other
No, no,
reason.
this irrespective of breach they have mentioned. What they have mentioned that breach has got a previous breach has got a higher risk. Okay. Most of these
Okay.
pregnancy happen in patients who have undergone cesarean section for the breech presentation. Okay.
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 So actually, you have already thorough with the article. So
No.
pathophysiology of cesarean scar pregnancy. Pathophysiology generally not asked. So we'll cut short this. Exact mechanism is not known, but the endometrial or myometrial scarring from previous C-section may predispose to abnormal implantation. Likely mechanism is that this blastocyst is invading through a microscopic tract in the scar, which is caused by the previous cesarean section. Prior surgery may affect endometrial receptivity. Okay, risk may relate to the size of the anterior uterine wall defect, and most of the cesarean scar pregnancies occur just after one cesarean section. So number of cesarean section is not directly correlated with the risk. Okay, so there is no correlation that higher the number of cesarean section, higher is the risk, because most of the pregnancies happen even after one cesarean section, and women who had cesarean section for breech presentation are at a higher risk. Basically, in these patients, generally the uterine incision is taken at a higher level because the lower segment is underdeveloped. Okay. Now, what is the chance of
Yes.
recurrence of cesarean section pregnancy? It is around 3.2 to 5%. That is 1 in 20. Okay. So sometimes, they twist the figure. We remember 5%, but they don't give 5% as such, they give 1 in 20. So we have to calculate. That means 5%. And under the exam stress, we are not, working in that fluently or alertly. So that is why I'm repeating this thing. So 3.2 to 5% is the risk of recurrence after the treatment with DINC plus minus uterine artery embolization. Risk factors for recurrence will be if the uterine segment thickness is less than 5 millimeter, G-sac bulging into the UV fold, if the cesarean section is performed in the rural hospital, and if there is a history of irregular bleeding and abdominal pain prior to the cesarean scar pregnancy, in subsequent pregnancy, there is likely to be a recurrence. Okay. Surgical repair may reduce recurrence by restoring the anatomy, but recurrence can still happen. Okay. So if you repair the scar along with the removal of this ectopic, there will be risk of recurrence will be reduced. That is what the talk article wants to say. Now, what is the classification of cesarean? There are two types, type 1 and type 2. Type 1 is endogenic. Okay, that means the implantation is on the scar, but the sac will grow towards the cervicoisthmic or towards the uterine cavity. Type 2, that is exogenic, where the sac will be embedded into the scar and myometrium, and it will grow towards the bladder. Sac may bulge through the thinning myometrium and increasing the risk of early rupture. Okay, so as the sac is increasing, the myometrium will become thin and the risk of rupture will be increased. In 2/3 cases, scar thickness is less than 5 millimeter. Okay. Now, what is the differential diagnosis? Up to 13.6% cases of Caesarean scar pregnancy are misdiagnosed as an inevitable abortion or cervical ectopic. Okay, they are misdiagnosed either as inevitable abortion or cervical ectopic pregnancy. What are the key differentiating features? So, Caesarean scar pregnancy will be fixed at the scar site. There will be absent sliding sign and there will be good Doppler flow. While miscarriage will have a first is a sliding sign. Okay, and Doppler flow will be less. Okay, the sac will be irregular. Doppler flow is less and sliding sign will be positive. Okay, cervical pregnancy, sac is near or inside the cervical canal. Cervix will be ballooned up. There will be negative sliding sign, but good Doppler flow. Okay, so that is how we differentiate. Then misdiagnosis can lead to this. You can go ahead with the surgical evacuation, and patient will end up with two complications which we discussed. One is a severe hemorrhage, and second is a hysterectomy. Okay, so MRI can assist when the ultrasound diagnosis is unclear, and especially in later gestation. Okay, so here also is a role of MRI. Okay. Now, diagnosis of Caesarean scar pregnancy on imaging. Ultrasound is the primary diagnostic tool for Caesarean scar pregnancy diagnosis. And here it is a combined transabdominal and transvaginal ultrasound. Remember, normally we in our first talk article we have mentioned about the role of TVS. Okay, but here it is a transabdominal and transvaginal ultrasound is required because that offers high diagnostic accuracy. Transabdominal will provide a panoramic view of the uterus as well as bladder, and especially useful in later gestation. So we have to see whether the sac is growing towards the bladder, towards the endometrial cavity, and how much is the myometrial thickness between the two. Okay, that also we need to measure. So combined transabdominal transvaginal ultrasound is going to be very important. The ultrasound features: gestation sac will be attached to the or embedded in the Caesarean section scar. Presence of yolk sac, embryo, and cardiac activity may mimic normal pregnancy, and prominent circular vascular flow around the sac on the Doppler. Okay, so these will be the features on the ultrasound. Okay. Now, next modality will be 3D ultrasound. Now, this 3D ultrasound with power Doppler, how it will help us? It will help us mainly the thickness of the myometrium. Okay, that you will be able to measure with the help of 3D ultrasound. Okay, so it provides enhanced imaging of the ectopic mass, helps to identify peritropoblastic vascular flow and measure the myometrial thickness, and it is not routinely required but useful in selected cases. Okay, then next is a MRI. It is helpful when the ultrasound is inconclusive, presence of fibroid or late gestation, and it offers additional anatomical clarity. Okay, so you have 2D, you have 3D, and MRI. Okay, so that is what is the role of imaging. Then what are the key
So if
principles?
there are three options, sorry, if there
Yeah,
are
yeah,
three
yes.
options, TVS, 3D, and MRI, which to choose?
Yes, Caesarean scar pregnancy. See, generally in that particular, look for a buzzword. Means from examination point of view, I'm saying if they use the word inconclusive, the ultrasound is done, but it was inconclusive, then MRI, go for MRI. Okay, if the
Okay,
word inconclusive, and generally such kind of words are there. Okay.
okay,
So, and this is taken directly from the TOG article, and that is why I prefer that, if the similar kind of sentence or the word comes, you go with that. Okay. But if it is not mentioned, then ideally the 3D ultrasound is going to be useful because it is important about the peritropoblastic vascular flow and myometrial thickness. Okay.
okay, okay, sir.
If it is previous investigation was inconclusive, then go for MRI.
Okay, sir.
Then key principles of from here we need to concentrate a lot because there are different types of management, and that is why you read the scenario very carefully. Okay, here we will first learn the general principles which will decide the which type of management we should go ahead. Okay, There is no consensus on a preferred treatment modality, point number one. Then treatment should be individualized and based on patient stability, gestational age, SCG levels, scar anatomy, and type of Caesarean scar pregnancy, whether it is a endogenic or exogenic. Our aim should be end the pregnancy early and preserve the fertility. Okay. All treatments carry risk of hemorrhage and hysterectomy. So two complications we have already discussed, this risk of hemorrhage and hysterectomy. Okay. Now we have medical management, we have embolization technique, and we have surgical management. Okay. So medical management is with methotrexate. It may be local injection, or it can be given systematically, or it can be combined also. Okay, so these are the three ways by which the medical management can be done. It is patient should be hemodynamically stable. It should be early pregnancy. The beta ICG should be on lower side. Advantage is that it avoids surgery but requires long follow-up. Okay. Now embolization techniques, that is uterine artery embolization or bilateral uterine artery embolization, chemoembolization. Okay. So it can be done alone, or it can be adjunct to the medical or surgical methods. It will control the bleeding and preserve the uterus. So if we are given a scenario, you look for these factors. Okay. Like whether she is interested in future fertility, and whether the patient is hemodynamically stable or not. So all these points we need to take into account. Third is the surgical management, in which we have simple D&C, then laparoscopic or laparotomy resection of this Caesarean scar pregnancy. Third is a hysteroscopy and transvaginal resection. Okay, these are the types in the surgical. Okay, this is suitable for higher SCG, larger mass, thin myometrium, and failed medical management. So when you have these higher levels, mass is larger, then we will look into the surgical, select surgical option. Okay, so read the scenario completely and then select the appropriate option. Then this surgical management will offer immediate resolution, and you can do the scar repair also, because you have to repair the scar, because the risk of recurrence will be reduced. Okay, so that particular option also, if she is interested in future fertility, then scar repair is also equally important. Okay, now coming to the medical management, which is with methotrexate. Here the criteria for the beta ICG, it should be less than 5,000 and the gestational age should be less than 8 weeks. Okay, slightly higher if you see from the medical management from the ectopic point of view, because they have given here the gestational age 8 weeks, and when we talk about 5,000, that means actually the cardiac activity should have been developed. Okay, so beta ICG less than 5,000, gestational 8 less than 8 weeks. If the scenario comes with these figures itself, then most likely we are dealing with the medical type of management, provided the hemodynamically stable patient is hemodynamically stable. Okay, but success rate with methotrexate alone is a 41% only without additional treatment. As usual, you have to monitor the blood count and LFT and RFT pre-procedure you have to do. Counseling is needed because prolonged follow-up is there and risk of surgery is always there. Second option is a local injection. You can inject methotrexate, you can inject KCl, etoposide, hyperosmolar glucose. Okay. Procedure is aspirate the gestational sac, inject methotrexate under ultrasound guidance, and resolution time will be proportional to the sac size. Okay, if more is the sac, more time will be required for the resolution and coming back the SCG level to the normal. Okay, if you combine this with systemic methotrexate, the success will be increased to 74%. Okay, with fewer intervention. So if you go ahead with only systemic method, it was a 41%, but if you go ahead with the local injection, it will be increased to 74%. Okay. Second is a chemoembolization. You can go ahead with the uterine artery embolization along with systemic methotrexate or local methotrexate used to reduce the bleeding during or after the surgery, and bilateral uterine artery chemoembolization along with the methotrexate you can do. It is reported 97.8, highest success rate in one of the series. Okay, limitation is that no direct comparative data and other treatments. Okay, clinical tips while answering, you should remember whether it is an exogenic type of CSP or whether we are dealing with endogenous type of CSP. If it is exogenous with thin overlying myometrium, prefer surgical option. If it is endogenic and better myometrial support, they have mentioned 2 millimeter. Okay, when they are discussing about the D and C, they have mentioned the better myometrial support minimum 2 millimeter. If it is given, then surgical option of D and C will be appropriate. And if you have a choice along with the scar repair, that can be chosen. Okay, and combination approaches, methotrexate plus uterine artery embolization or methotrexate plus surgery often improves the outcome. Scar defect repair during the surgery may reduce the recurrence risk. Okay, so these are the different options, and these are the specific things which are given in the talk. Okay, so DNC or suction curettage, this is suitable for the endogenous CSP, and the myometrial thickness should be 2 millimeter or more. It requires ultrasound guidance, and risk of incomplete evacuation is there, and bleeding is also there. Foley's catheter or cervical suture, this is not a very, they can be used to control the bleeding actually during the DNC. Then second is a laparoscopic or open resection. That is laparoscopy or laparotomy, but laparoscopy will be preferred. Okay, and this is possible for an exogenous type of CSP and thin myometrium. Okay, and preferred because you can repair the defect also, and it is going to be a definitive treatment. Then hysteroscopic resection, generally after the methotrexate management or the remnant of the mass post methotrexate, or it can be considered as a primary treatment also. But for primary treatment, generally uterine artery embolization is also required because this can have a bleeding. So you go ahead with the uterine artery embolization. Okay, so it can be combined with the laparoscopy or uterine artery embolization. Okay, then transvaginal resection, alternative to laparoscopy, and allows defect closure, similar recovery outcomes. Okay, so these are the different modalities of the management in the Caesarean scar pregnancy. So appropriate management will have to select depending upon the scenario which is given. Okay, so there are two things. One is a combined management and second is a sequential management. Combined management means two different modalities are used together. Sequential management means one modality is used and then some interval is given and then the other modality is used. Okay, that means medical management may be used first, and over a period of time then there is an intervention of the surgical management. Okay, while in combined, both modalities are put together. Okay, so combined management involves using more than one modality, like uterine artery embolization along with methotrexate. Okay, so uterine artery embolization will reduce the bleeding risk during the suction evacuation, and methotrexate help to absorb the residual trophoblastic tissue. So combined approach reduces the risk of the bleeding, hysterectomy chances are reduced, recovery will be early. So typical evacuation time is 24 to 48 hours after chemoembolization. So you do the chemoembolization and then you carry out the surgical evacuation after 48 hours. That is what is the combined management. It is useful in moderate to heavy bleeding cases, and uterine artery embolization will be complications will be fever, pain, infection, amenorrhea, premature ovarian aging, etc. Residual tissue after embolization can rupture or recur, or there can be recurrence. Okay. What is a sequential management? One method followed by another after a time interval. That means initially methotrexate is given, followed by the surgery. Used when medical treatment fails or symptoms persist. Resolution may take up to 6 months, or even if the mass is larger, it may take more than a year also. Risk will be infection, AV malformation, prolonged morbidity. Surgical intervention may include evacuation or resection. Preferred sequential when CSP mass is large or persistent. Okay, good outcomes with surgery 7 days post methotrexate. In sequential cases, some need further intervention. Okay, and SCG levels don't predict blood loss accurately. Expectant is not a very preferred management for the Caesarean scar. So as far as option point of view, unless it is very, very clear that there is a drastic reduction in the beta SCG, this option is not a very suitable option. Okay, so it is high risk because 67% require further treatment and 29% may end up with hysterectomy also. It is suitable for non-viable CSP, declining SCG, and asymptomatic women. Not recommended for viable CSP, rarely used when patients decline termination despite risk, must involve clear counseling and close monitoring, plan for cesarean delivery if the pregnancy continues. Okay. Then another is a heterotopic pregnancy with Caesarean scar pregnancy. That is rare. but one sac is in the Caesarean scar and other is in the uterine cavity. Possible to inject the KCl into the Caesarean scar pregnancy and continue the intrauterine pregnancy. Exogenous CSP can be removed via laparoscopy or laparotomy. Risk of bleeding and loss of normal pregnancy still remains. Okay. So choosing the treatment options, we have seen so many options. So what are the key points? Okay. First, individualized based on patient factors. Expectant management is generally not recommended except in rare cases. So this option will be, we are not going to select unless it is a very clear cut case. Then medical management for stable and asymptomatic women, less than 8 weeks and SCG level less than 5,000, medical management. Intralesional methotrexate plus sac aspiration has got a higher success rate. Okay. So that kind of option we will look for. Then surgical treatment is preferred for symptomatic women, those who decline medical management. Okay. If it is an endogenous CSP, surgical evacuation or hysteroscopic resection will be preferred. If it is an exogenous CSP, surgical resection with defect repair will be chosen. And in that case, we have two options, transvaginal or laparoscopy. That is better than the laparotomy. Okay. So better to select laparoscopy over the other. Okay. So use combine sequential treatments for longer gestation and failed or incomplete initial treatment. So that will be combine or sequential treatment. Okay. So follow-up and future pregnancies, SCG decline and mass resolution will take longer with the medical than the surgical treatment. Expect initial SCG rise after the methotrexate due to the necrosis and bleeding. Provide adequate counseling about duration, complication, and need for further intervention. Treating center must have emergency facilities. Scar defects may require resuturing before next pregnancy. Successful future pregnancies are possible after cesarean section pregnancy, cesarean scar pregnancy. Then recommend early ultrasound to rule out recurrence. Monitor for morbidly adherent placenta, and all reported cases are delivered by the cesarean section only. Okay. So that finishes our topic on Caesarean scar topic.